Welcome to the Oncology Data Advisor podcast, where we explore the latest advances in medical research and treatment. This episode is provided by i3 Health. I am Katie Cook. The introduction of targeted oral oncolytic therapies has shifted the treatment landscape for chronic lymphocytic leukemia, or CLL. Pharmacists play a crucial role in optimizing treatment with these therapies, including navigating medication access, monitoring safety, providing patient education, and optimizing adherence. In this podcast episode, Dr. Kelsey Marciano, clinical pharmacy specialist at UC Health, will explore pharmacist-led strategies for treatment selection and toxicity management to optimize CLL care. This activity is supported by a medical education grant from B1 Medicines USA, Inc. Free CPE credit is available for this podcast. To claim credit and obtain further information, including faculty disclosures, visit i3health.com/podcasts.
Hi, everyone. My name is Kelsey Marciano, and I am a clinical pharmacy specialist in hematologic malignancies and bone marrow transplant at University of Colorado Health. And today I'm going to be discussing optimizing CLL care, specifically pharmacist-led strategies for treatment selection and toxicity management. I have no relevant financial relationships to disclose, and i3 Health has mitigated all relevant financial relationships. The learning objectives are to provide informed treatment recommendations as part of the care team to maximize efficacy and minimize intolerance of novel agents in CLL, develop evidence-based dose modification and supportive care strategies for managing toxicities of these agents, implement pharmacist-led patient education approaches to enhance treatment understanding and promote self-monitoring of adverse events, and describe the unique role of pharmacists as part of the interprofessional team in enhancing patient care. Information reviewed today will include epidemiology and clinical burden, individualizing treatment decisions, toxicity profiles and monitoring protocols, management strategies, patient education and medication adherence, interprofessional collaboration, as well as a case presentation. Starting with epidemiology and clinical burden, CLL, or chronic lymphocytic leukemia, results from a genomic alteration that leads to leukemic transformation and monoclonal expansion of B lymphocytes within the blood, bone marrow, lymph nodes, and spleen. It's the most common type of leukemia, and the incidence is higher in males compared to females. The estimated new cases in 2025 is around 24,000, which is 1.2% of all new cancer cases. And the estimated deaths in 2025 from CLL are around 4,500, which is 0.7% of all cancer deaths. The 5-year relative survival is approximately 89%. The median age at diagnosis is 70 years, and the median age at death is 82 years. CLL is an indolent disease, and it's important to note that B-cell lymphoma 2 or BCL2 overexpression leads to prolonged cell survival. And the difference between CLL and small lymphocytic leukemia, or SLL, is that SLL is characterized by the presence of lymphadenopathy but absence of cytopenias, and is diagnosed when there are less than 5,000 B lymphocytes per microliter in the peripheral blood, whereas a CLL diagnosis requires at least 5,000 B lymphocytes per microliter in the peripheral blood for at least 3 months. Moving on to individualizing treatment decisions. Indications for treatment include being eligible for a clinical trial, significant disease-related symptoms, threatened end organ function, progressive symptomatic or bulky disease, progressive thrombocytopenia or anemia, and steroid refractory autoimmune cytopenias. So if patients have any of these indications, then they would be recommended to receive treatment. And as there is no cure for CLL, the goal of treatment is to palliate symptoms and extend survival. The NCCN preferred regimens for frontline therapy are Venetoclax and obinutuzumab, Venetoclax, acalabrutinib with or without obinutuzumab, and those are both BCL2 inhibitor containing regimens. Acalabrutinib with or without obinutuzumab, and zanubrutinib, and those last two are BTK inhibitor based regimens. The clinical trials that led to these recommendations are Elevate-TN, which demonstrated a significantly longer progression-free survival with acalabrutinib plus or minus obinutuzumab compared to chlorambucil and obinutuzumab. The CLL-14 trial, which showed a longer progression-free survival with venetoclax and obinutuzumab compared to chlorambucil and obinutuzumab. The Sequoia trial, which showed a longer progression-free survival with zanubrutinib compared to bendamustine and rituximab. And the Amplify trial, which determined a longer progression-free survival with acalabrutinib, venetoclax, with or without obinutuzumab compared to chemoimmunotherapy. When deciding on the first-line treatment, it's important to consider genetic risk, specifically that chemoimmunotherapy is not recommended in patients with deletion 17p or TP53 mutation due to low response rates, as well as patient comorbidities. For instance, it's recommended to consider avoiding BTK inhibitor therapy in patients with cardiovascular comorbidities, such as uncontrolled arrhythmia in patients with high bleeding risk. And drug-drug interactions should also be reviewed. And then finally, relapse risk associated with treatment. For example, resistance mutations that are associated with BTK inhibitor therapies and that fixed duration BCL2 inhibitor containing regimens have been shown to be more likely to achieve undetectable minimal residual disease, or MRD. NCCN preferred regimens for second-line therapy include venetoclax with or without obinutuzumab, and of note, patients can be retreated with this regimen after a period of remission. Acalabrutinib, zanubrutinib, and pirtobrutinib if the patient has had resistance or intolerance to prior covalent BTK inhibitor-based regimens. Treatment selection considerations for subsequent therapy include the depth and duration of response, as well as toxicities with first-line regimens, cytogenetic risk, patient fitness and comorbidities, route of administration, frequency of clinic visits, patient preference, medication access, including insurance coverage and cost, and number of prior lines of therapy. Patients that are refractory to BTK inhibitor-based and BCL2 inhibitor-containing regimens have poor outcomes and limited treatment options. NCCN preferred regimens for these patients are Lisocabtagene, which is CD19-directed CAR T-cell therapy, which requires frequent transportation and caregiver support, and pirtobrutinib if not previously given. However, responses from pirtobrutinib are typically not durable, so it's often considered as a bridge to CAR T-cell therapy. Other considerations include an allogeneic hematopoietic cell transplant in the absence of significant comorbidities, and a clinical trial. Of note, PI3K inhibitors are in the NCCN guidelines, but they're only utilized when no other options are available due to limited efficacy and toxicity risks such as infections and immune-related complications. Venetoclax with or without obinutuzumab is an option for subsequent therapy due to studies showing superior efficacy of obinutuzumab compared to rituximab in first-line therapy, as well as real-world evidence demonstrating efficacy of the combination for relapse and refractory disease, and retrospective analyses suggesting efficacy of retreatment with venetoclax-containing regimens. Treatment with acalabrutinib led to significantly improved progression-free survival compared to investigators' choice in the ASCEND trial, and treatment with zanubrutinib resulted in significantly prolonged progression-free survival compared to ibrutinib in the ALPINE trial. In the BRUIN trial, pirtobrutinib led to an overall response rate of around 73% and a median progression-free survival of 19.6 months. And the patients in this trial all have received a previous BTK inhibitor, and around 40% of patients had also received prior Venetoclax. This trial led to an FDA approval for patients who have received both a BTK inhibitor and Venetoclax. The Transcend CLL-004 trial evaluated Lisocabtagene in patients who have received at least 2 previous lines of therapy, including a BTK inhibitor, and reported a median progression-free survival of around 12 months and a median overall survival of around 43 months. The CLL International Prognostic Index, or CLL-IPI score, is the main prognostic score used in CLL and takes into account the presence or absence of a deletion 17p or TP53 mutation, IGHV mutational status, serum beta-2 microglobulin, clinical stage, and age. Other prognostic factors include the presence or absence of the deletion 11q or deletion 13q mutations. It's also been shown that MRD, specifically undetectable MRD, which is defined as less than 1 CLL cell per 10,000 leukocytes in the blood or bone marrow, improves long-term outcomes and may be used to guide treatment duration. Shifting gears to toxicity profiles and monitoring protocols. Looking at BTK inhibitors, so just to review the mechanism of these agents, ibrutinib is our first generation BTK inhibitor, so it tends to have more off-target effects, whereas acalabrutinib and zanubrutinib are our second generation BTK inhibitors, which are typically better tolerated. Pirtobrutinib is a non-covalent BTK inhibitor. So this is a newer agent that works differently than ibrutinib, acalabrutinib, and zanubrutinib. Its unique binding to the ATP pocket of BTK allows it to be effective in patients with the C481 mutation. Looking at the side effects of BTK inhibitors, the main class side effects are hypertension, bleeding, atrial fibrillation, diarrhea, headache, arthralgias, neutropenia, infections, and fatigue. Of note, the cardiovascular adverse effects are most common with ibrutinib, and diarrhea and headache are the 2 most common side effects seen with acalabrutinib. It's recommended to monitor for drug-drug interactions since all of these agents are strong CYP3A4 substrates. And it's also recommended to monitor the CBC regularly, typically monthly or as clinically necessary. However, it's important to not interrupt treatment for redistribution lymphocytosis, since that is the transient mobilization of lymphocytes into the blood, and that means that the medications are working. And it's also recommended to refer to the package insert for any dosing and holding recommendations around procedures. The toxicities of Venetoclax include thrombocytopenia, anemia, fatigue, diarrhea, nausea, and infections. As mentioned before, BCL2 is an anti-apoptotic protein, and this protein is overexpressed in CLL cells. So when Venetoclax inhibits BCL2, this leads to apoptosis of CLL cells. The Venetoclax dose is titrated weekly to minimize risk of tumor lysis syndrome, and neutropenia is seen more frequently when Venetoclax is combined with obinutuzumab. Anti-CD20 monoclonal antibodies include rituximab, which is chimeric, and obinutuzumab, which is humanized with enhanced antibody-dependent cellular toxicity, which leads to more effective B-cell depletion. The hepatitis panel should be drawn prior to treatment initiation due to the risk of hepatitis B reactivation. Infusion reactions are pretty common, therefore pre-medications and a conservative initial infusion rate are recommended. Tumor lysis syndrome and rarely progressive multifocal leukoencephalopathy, or PML, are also risks to be aware of. Toxicities of lysocell include cytokine release syndrome, or CRS, neurological events, prolonged cytopenias, infections, hypogammaglobulinemia, and second primary malignancies. It's recommended to monitor patients for at least 14 days following the cell infusion and daily for the first 7 days for signs and symptoms of CRS and neurologic toxicities, which include fever, hypotension, chills, tachycardia, and hypoxia for CRS, and for neurologic toxicities, encephalopathy, tremor, aphasia, delirium, headache, and seizures. Patients should be instructed to remain within proximity of a healthcare facility for at least 2 weeks following the infusion and advised to avoid driving for at least 2 weeks following the infusion. So how do we manage these toxicities? For BTK inhibitors, the package insert describes indications for treatment interruptions, dose modifications, and treatment discontinuation. In general, treatment should be interrupted for any grade 3 or higher non-hematological toxicities, with recommendations for hematologic and cardiovascular toxicities differing slightly among the agents. The Venetoclax and obinutuzumab package inserts describe indications for treatment interruptions, dose modifications, and discontinuation. Of note, it's recommended to consider reinitiating Venetoclax at a lower dose if treatment is interrupted for more than 1 week during dose escalation or more than 2 weeks at target dose. It's also recommended to consider discontinuing Venetoclax for patients who require dose reductions to less than 100 milligrams for at least 2 weeks. Supportive care measures for BTK inhibitors include hypertension. So in cases of hypertension, initiating or adjusting antihypertensive therapy as appropriate is important. And then for acalabrutinib, as headache is one of the most common side effects, it's important to counsel patients on the utilization of hydration, analgesics, and caffeine for these headaches. Venetoclax and obinutuzumab require constant monitoring for tumor lysis syndrome. For example, prophylaxis is recommended with oral hydration and allopurinol, with or without IV hydration, depending on the patient's risk of tumor lysis syndrome. Frequent lab monitoring is required, as mentioned, and this frequency depends on the patient's tumor lysis syndrome risk and the dose of the medication. And the patient's tumor lysis syndrome risk is based on the lymph node size and the absolute lymphocyte count. Typically, lab monitoring is recommended for 6 to 8 hours and 24 hours following the first 20 milligram and 50 milligram dose and prior to each subsequent initial ramp-up dose. And patients that are high risk for tumor lysis syndrome should be admitted to the hospital for extra close monitoring. For neutropenia, it's recommended to consider infection prophylaxis with antimicrobials and G-CSF, especially during dose escalation, in order for patients to reach the target dose. Supportive care measures for CAR T-cell therapy, specifically managing CRS, include supportive care such as fluids, vasopressors, and oxygen as appropriate, as well as treatment of CRS with tocilizumab with or without corticosteroids. And anakinra is often indicated for refractory treatment of CRS. For neurotoxicity, dexamethasone is standard of care, in addition to levetiracetam for seizure prophylaxis. Additionally, it's often recommended to avoid sedating medications and to consider a neuroconsult for these patients. IVIG should be administered as appropriate for hypogammaglobulinemia. And management of cytopenias really depends on the etiology, but may include GCSF, transfusions, infectious prophylaxis with antimicrobials, TPO agonist, and or stem cell boosts. When thinking about patient education and medication adherence, it's important to make sure patients know the pros and cons of treatment options. For Venetoclax and obinutuzumab, the pro of this option is the fact that it's a time-limited duration of 12 months, with obinutuzumab given cycles 1 through 6 and Venetoclax given cycles 1 through 12. Some cons include the fact that transportation and time is required for obinutuzumab administration since it's an IV infusion, and frequent lab monitoring for tumor lysis syndrome surveillance is involved. For Venetoclax plus acalabrutinib plus or minus obinutuzumab, this is also a time-limited duration, which is a pro. It is a 14-month treatment with acalabrutinib being given cycles 1 through 14, obinutuzumab given cycles 2 through 7, and Venetoclax given cycles 3 through 14. Some cons include that there is frequent lab monitoring that's necessary for TLS surveillance, and obinutuzumab also requires transportation and time required for administration. So the cons are similar to Venetoclax and obinutuzumab. However, since Venetoclax doesn't start until cycle 3, the risk of tumor lysis syndrome is likely lower since there's some debulking that has been taken place prior to initiation of Venetoclax. For acalabrutinib, with or without obinutuzumab, the pros are that it is an oral option. So this is very convenient for patients. The dose for acalabrutinib is 100 milligram twice a day. And if we add obinutuzumab, this is a time-limited therapy for the obinutuzumab, as that medication is only given for cycles 1 through 6. However, some cons of this treatment are that acalabrutinib is given indefinitely. This leads to a potential for increased financial burden. And if we add obinutuzumab to acalabrutinib, of course, the transportation and time required for administration of obinutuzumab is also a potential con. And lastly, zanubrutinib. This is also an oral option, so the convenience is there for patients. And with zanubrutinib, there is an option for once-a-day dosing. So patients can take 320 milligrams once a day, as well as 160 milligrams twice a day. So there are 2 different dosing options for zanubrutinib. The cons are similar to acalabrutinib, with it being an indefinite therapy, and this can lead to a potential for increased financial burden. When I talk to patients about self-monitoring and reporting adverse events, I tell them they should call the healthcare team if they have a fever, which is defined as at least 100.4 degrees Fahrenheit, any signs or symptoms of infection, such as congestion, cough, sore throat, trouble breathing, and pain or trouble urination, as well as any changes in heartbeat or rhythm, such as feelings of the heart skipping a beat, since there is that risk of atrial fibrillation with the BTK inhibitors. If patients notice any bleeding at home, as well as any diarrhea not relieved by loperamide, any nausea unrelieved by antiemetics, any signs of CRS or neurologic toxicity, and really just any other new or worsening symptoms. I also tell them to call prior to starting any new medications so drug-drug interactions can be reviewed. And at UC Health, we do provide patients with a magnet that has all of the indications that give them a sign that they need to call the healthcare team. And any patient getting CAR T-cell therapy is also given a wallet card that discusses the signs and symptoms of both CRS and neurologic toxicity. There is a list of patient and caregiver resources in the slide deck associated with this recording, but some notable resources are Cancer Care, CLL Society, Leukemia and Lymphoma Society, and NCCN. Interprofessional collaboration is critical for successful management of patients with CLL. Focusing on a multidisciplinary approach and effective communication within the oncology care team is crucial for optimal patient care. Oncologists typically explain CLL treatment options and monitoring with patients based on stage and prognosis, and they regularly review any new drug approvals and/or updated guidelines to ensure optimal patient care. Nurse navigators ensure patients understand the plan, review appointments, and discuss medication access with patients. They also provide guidance through the healthcare system and coordinate care for the duration of the patient's journey. Pharmacy liaisons and financial care coordinators submit prior authorizations for treatments and work with patients to obtain financial assistance if needed. They also contact patients to set up prescription dispensing through pickup or mail delivery. The specialty pharmacy team provides refill reminders and follow-up calls. Infusion nurses administer treatment and provide bedside care. Social workers provide emotional support and assist with transportation, housing, food, childcare, home care, and many more. Psychologists and psychiatrists provide mental health support. Dietitians help patients with appetite issues, weight management, and difficulty eating or drinking. The palliative care team helps with symptom management, and clergy provides spiritual counseling. So all of these members of the team have irreplaceable roles. Additionally, patients should be encouraged to partake in shared decision-making, as this really leads to patient empowerment as well as patient satisfaction. The clinical pharmacist role within the oncology team is to assist with medication dosing while considering evidence-based medicine and patient-specific factors, identify drug-drug interactions in any drug administration concerns, meet with patients to provide treatment education, encourage patients to reach out with any questions or concerns, provide supportive care recommendations, including prevention of nausea and infections. They also provide monitoring recommendations, assess adherence and toxicity through patient check-in calls, and provide adherence tips as appropriate, for instance, pill boxes and phone reminders. Pharmacists manage toxicity throughout treatment by assisting prescribers with any dose modifications, treatment interruptions, and supportive care. Pharmacists also provide medication-related information to colleagues and consider emergency response protocols and/or any collaborative practice agreements, which really allow pharmacists to practice at the top of their license and maximize their impact. Next, I'll be discussing a case study regarding management of a complex case of CLL. Mr. GE is a 68-year-old man with a diagnosis of CLL and a history of controlled hypertension. However, he has been experiencing persistently elevated blood pressure since initiation of ibrutinib. His current medications are ibrutinib 420 milligrams once a day and amlodipine 5 milligrams once a day. How would you manage his hypertension? So, Mr. GE's oncologist consulted his primary care physician, and the patient's amlodipine was increased from 5 milligrams to 10 milligrams once a day. And although this improved, his blood pressure did continue to be elevated following the dose adjustment. The patient is resistant to adding a second antihypertensive medication and would like to remain on amlodipine due to history of intolerance to other alternatives for hypertension. Therefore, ibrutinib was temporarily discontinued. 1 week later, it was resumed as the blood pressure had normalized. However, unfortunately, the patient's hypertension recurred 1 week following resumption of ibrutinib. The decision was made to then switch Mr. GE's CLL treatment. Some things that the patient mentioned when discussing the treatment switch was that transportation is pretty difficult for him, and he also mentioned that he struggles to take any oral medications that need to be taken more than once per day. So knowing these thoughts the patient had, what treatment option may be best for Mr. GE, and what factors contributed to that decision? So due to these transportation and adherence concerns, the oncologist determined it would be best for the patient to remain on a once daily oral medication. So he was switched to zanubrutinib 320 milligrams once a day. To expand on this treatment decision, there is no need to switch treatment mechanism or class since he did not progress on a covalent BTK inhibitor. So acalabrutinib and zanubrutinib are both options, as they are the other two covalent BTK inhibitors, and they're both less likely to cause cardiovascular toxicities. However, acalabrutinib is only approved for twice daily dosing, and so that led to the decision to treat the patient with zanubrutinib. And it's important to note that even though pirtobrutinib is a BTK inhibitor, it is a non-covalent BTK inhibitor that should really be reserved until the patient truly fails BTK inhibitors that are covalent. And since this patient was doing well, regarding his CLL when being treated with a covalent BTK inhibitor, there isn't a need to switch to pirtobrutinib. It's just important to switch to another covalent BTK inhibitor that the patient may tolerate better. So as a pharmacist, what are some key points you would include in your zanubrutinib education visit? The pharmacist did educate the patient on zanubrutinib, and they encouraged the patient to take zanubrutinib at the same time as he took ibrutinib to avoid confusion during the transition and just to really make that transition as smooth as possible. They also reinforced the need to take 4 80 milligram capsules once a day. And the patient was agreeable to this increased number of pills required and will plan to switch to taking 2 of the newly approved 160 milligram tablets once that new formulation is available. The pharmacist also reviewed potential adverse effects, which are very similar to those of ibrutinib with some key differences. Overall, zanubrutinib is much better tolerated than ibrutinib. It does have an increased risk of neutropenia. However, it has a decreased risk of most of the other side effects, including arthralgias and cardiovascular toxicities. The pharmacist instructed the patient to call with any new or worsened symptoms, such as fever or any signs of infection, abnormal bleeding, rash, arthralgias, fatigue, or changes in heartbeat, such as palpitations. They also reminded the patient of the need to call in case of any planned medical or dental procedures, as there are recommendations for holding the zanubrutinib around procedures. The pharmacist also explained that the patient will get routine CBC monitoring while on treatment, with more frequent lab checks for the first 1 to 2 months per the oncologist. Another discussion point: how would you monitor for and manage cardiovascular toxicities while Mr. GE is taking zanubrutinib? So, although there is a lower risk of cardiovascular toxicities with zanubrutinib, it's still important to monitor closely. Cardiovascular monitoring includes a pre-BTK inhibitor workup. So prior to patients initiating any BTK inhibitor, it's recommended to obtain a comprehensive medical history, an ECG, and a blood pressure measurement. An echocardiogram should be considered as well in the presence of high cardiovascular risk or established cardiovascular disease. It's also recommended to monitor blood pressure routinely throughout therapy, with a specific recommendation of monitoring biweekly in patients that have pre-existing hypertension, such as Mr. GE. Patients should be educated about potential symptoms of cardiovascular side effects, and it's important to consider consultation with the patient's primary care physician if hypertension or any other cardiovascular side effects occur. Additionally, it's important to remember that blood pressure elevation really should be promptly treated, as uncontrolled hypertension is a defined risk factor for other cardiovascular toxicities such as atrial fibrillation. If hypertension occurs, the patient's lifestyle should be assessed, as lifestyle risk factors for hypertension include obesity, alcohol intake, smoking, and stress. Next, guideline-directed pharmacological management should be initiated. Importantly, non-dihydropyridine calcium channel blockers should be avoided in patients taking BTK inhibitors, since there is a drug interaction. Finally, cardiology should be consulted in any complicated case, including cardiovascular toxicity. To conclude this session, key takeaways to keep in mind are that CLL is an indolent disease that does not always require treatment. Treatment decisions should take into consideration prognostic risk, patient comorbidities, patient preference, resources required, and prior treatments, including efficacy and safety of those prior treatments, if applicable. Toxicity monitoring and management play a large role in the treatment of CLL, and a multidisciplinary approach to CLL management, including a pharmacist, is crucial for optimal patient care. And my references are included in the slide deck associated with this recording.
Thanks for tuning in to the Oncology Data Advisor podcast. If you haven't already, be sure to subscribe so you'll never miss an episode. To claim CPE credit for this activity, visit i3health.com/podcasts. You'll also find plenty of other free educational resources and offerings. And don't forget to connect with us on social media for free CE activities, news, exclusive interviews, and more.